Good morning. I'm Al Charbonneau, Executive Director of the Rhode Island Business Group on Health. Thank you for joining us in this important employer discussion, uniting to reduce the impact of chronic disease in Rhode Island. I'd like to begin by thanking our sponsors who support RIBGH's work, including this morning's discussion. I know I speak on behalf of the RIBGH board and our members when I say we are truly grateful to our platinum sponsor, Mercer, our gold sponsors, Blue Cross and Blue Shield of Rhode Island, Hilb of New England, United Healthcare, Neighborhood Health Plan, Tufts Health Plan, and Aetna. Our silver sponsors, USI Insurance Services, Merck, Gallagher, and Delta Dental. And and not to be forgotten, our RIBGH members, a growing group of 90 plus companies representing over 80,000 employees. I also know I speak on behalf of the RIBGH board when I say thank you to the RIBGH Health and Productivity Committee, which is responsible for today's event. The H&P committee is co-chaired by Robin Bouvier from Aon and Jean Tapley from Amica Insurance. I also want to thank Joanne Bellata, Melissa Porcelli from Novo Nordisk, Dana Brundage for organizing today's event. It is also my pleasure to introduce Robin Bouvier, Vice President, Health Transformation for Aon and co-chair of the H&P Committee. Robin will introduce today's panelists. Thank you.
Great. Thank you, Al, and good morning, everyone. As Al said, my name is Robin Bouvier from Aon. As you can see, I'm wearing red today for World Heart Day, so happy World Heart Day to all of you. But red is also the color of Aon. And Aon recently initiated a rebranding campaign. The new Aon story is, we are in the business of better decisions. We shape decisions for the better to protect and enrich the lives of people around the world, which is exactly why we're here today, to help individuals, their providers, employers, and communities make better decisions in the areas of risk reduction and treatment of non-communicable diseases like heart disease and diabetes, which represent both top health plan cost drivers and causes of death worldwide. So as Al said, I'm going to go ahead and introduce our panelists. They'll each share a little bit of information with you about their current role, as well as their experience working in this particular area. So I'm going to start with Tom Hubbard. Tom, can you please introduce yourself?
Yes, hi everybody. My name is Tom Hubbard. I serve as Vice President of Policy Research for an organization known as NEHI, N-E-H-I. That acronym originally stood for New England Healthcare Institute. We are a nonprofit, nonpartisan health policy organization, basically a small think tank. We, many years ago, rebranded ourselves away from the New England Healthcare Institute, keeping that acronym, but our focus is on US healthcare in general, systemically, and our program is built around the active membership of about 70 organizations that span sectors in healthcare. So payers, providers, biopharma, patient advocates, pharmacy, and so on. So we're basically devoted to a mission of trying to find common ground around difficult issues in healthcare, generally from I'll say a sort of triple aim kind of perspective. What's better for patients? What's better in terms of financial sustainability of the healthcare system? What's going to lead to a better experience for all? So I'll leave it there for the moment, I guess, Robin.
Wonderful. Thank you, Tom. Neil Goldfarb, can you please introduce yourself, Neil?
Good morning, everybody. Neil Goldfarb, President and CEO of the Greater Philadelphia Business Coalition on Health. So we're one of your sister coalitions to the south, covering Philadelphia and suburbs, Delaware, and southern New Jersey. We have 50 employer member organizations representing around 1.5 million lives. So Al just taught me this morning that that's more lives than exist in all of Rhode Island. But despite Rhode Island's relatively small size, you've got some great brain power there. I consider Al a colleague and friend and look to him often for advice. And then we're both members of the National Alliance of Healthcare Purchaser Coalitions, which networks us with the 48 other coalitions around the country so that we can all learn from each other.
Wonderful. Thanks, Neil. And before I introduce our final panelist today, I just want to make sure that we're all making the connection. As we think about helping to reduce the incidence and severity of these preventable chronic conditions, we also need to take into consideration the total well-being, the emotional and mental health of the population, and the role that that plays in people achieving health and helping them to thrive. And I think a theme that we're seeing during, and hopefully we will see post-pandemic, is this concept of resilience. And resilience comes from an equation, maybe gratitude, empathy, and mindfulness. And so as I introduce our final panelist, Ernestine Jennings, after she introduces herself, I've asked her to just take a moment to do a quick mindfulness practice to help all of us take a moment to arrive. So Ernestine, if you could go ahead and get started. Thank you.
All right. Thank you, Robin. Yes, I'm Ernestine Jennings, and I am a clinical psychologist. I work in the area of health behavior change and physical activity and smoking cessation are my areas of research. But I also do work within primary care settings, working with patients day-to-day on issues in terms of dealing with chronic health issues. So thank you for the invitation. And in terms of the mindfulness moment, I'd like to take just a few moments to kind of ground us and kind of get us oriented together. I know we're all here to learn more, and I just want us to kind of meet together. So what I usually have people do is really just take a moment and really let's pay attention to our breath, and taking some slow, deep breaths to begin. I want us to just become just aware of our body and the fact that we're sitting here, noticing how our body is making contact with our chair, or if we're standing, our feet are making contact with the floor, and just noticing that, and notice how your clothes feel against your skin. And then I want you to think of a metaphor. Within the strong turbulent winds of a hurricane, I want you to think of the eye. The eye is the center of the hurricane. It's quiet. There's no wind and no movement there. For a moment, I want you to picture this idea in your mind. Can you visualize the strong turbulent winds of a hurricane, and then the inner core that's truly peaceful and quiet? And I want you to see if you can become like the center of this hurricane. Your current circumstances, your thoughts, your feelings, all the sensations in your body can be compared to the wind of the hurricane. But I want you to think about, you're no longer taking part in all that. You're the I. And to do that, I want you to focus on your breathing. Simply breathe in and breathe out, and then focus inward. And just like the I that's deep within the hurricane, your I is deep within you. And use your breath to connect to that part of you, breathing in and out, and staying connected to your breath. Notice that you have things whirling around you, but you are not them. You are the silent center of this hurricane, the part that is peaceful despite what is happening to you. And then as you're breathing, I want you to notice how you move toward the center of the hurricane, keeping your eye focused on being that eye, being the center, breathing in, breathing out. And as you sit here, connected to the eye, notice what arises. Notice that the wind is there. Notice that you have these sensations, but you're watching from a distance. You're no longer in the wind. And the goal is to watch without reacting to what you see. You remain the eye. Just breathe in and breathe out, and visualize yourself in the center. It can be difficult to see the eye of the hurricane at times, and sometimes we forget the eye is there. But I want you to remember that it's always there. And if we examine close enough, even the strongest, darkest hurricane, sooner or later, we'll see the eye centered and constant. Now, when you feel ready, you can slowly open your eyes and remain as the eye at peace.
Thank you, Ernestine. What a great way to start the meeting and help everyone be fully present in this moment. But it also is a really great segue into our panel discussion, because if we can think about the experience people who have heart disease or diabetes may be having, they may actually feel like they're the ones that are spinning around in the hurricane. Their lives are out of control. Maybe they feel like they're slowly dying. Maybe they're feeling helpless or hopeless. So hopefully through our conversation today, not only will we reduce the number of people that are in that hurricane, but we can help to create a more positive and empowered experience for people who may be struggling and living with these diseases. So that's wonderful. Thank you so much. So I'd like to start my first question to Tom. Can you discuss a little about NEHI's policy brief entitled Obesity and Type 2 Diabetes, Prevention and Treatment? Together remain critical priorities to protect the health of Americans and sustain long-term affordability of healthcare.
Yes, thanks, Robin. So just to sort of reintroduce this to everybody. So we are a small think tank headquartered out of Boston. And as I described, we're build our program around the shared interests of organizations that span multiple healthcare sectors. Our members include most of the insurers and health plans in New England, including ones active in Rhode Island. And going back 3 years ago now, so pre-COVID pandemic, we were very interested in looking at what was the status of policy and practice and clinical guidance related to type 2 diabetes, and I'll say a little bit secondarily obesity, and that from sort of the mindset that, traditionally we look at treatment of type 2 diabetes and prevention of type 2 diabetes as being grounded in lifestyle modification, which is basically about preventing or reducing obesity. So physical activity, dietary interventions, and so on. And long story made somewhat shorter, I think what we came to appreciate very quickly was there was sort of good news, bad news in this situation. The good news in a lot of ways, and I think we'll talk about this before the end of the panel, a lot more in sort of the toolkit around preventing type 2 diabetes by reducing or reducing the impact of obesity in various ways. We did our project sort of hard on the heels of Medicare approving what a lot of folks in the audience may know this, the DPP, Diabetes Prevention Program, which was the first sort of coordinated program involving diet and fitness that was tested in a randomized clinical trial, tested out through YMCAs. YMCAs in New England were very active in this, are very active in this, and approved as a Medicare benefit. And it was going straight at the issue of reducing or preventing obesity as a way to get at diabetes downstream. And a lot of other things were happening and are continuing to happen. In fact, I dare say for those of you on the call who are in the human resources or benefits design, purchasing end of things for your company, your inbox is probably flooded with new programs, interventions, digital tools, and so on. And increasingly the news about what's now more generally known as anti-obesity medications, AOM. So drugs, I think mostly originally designed for treatment of type 2 diabetes, which are now proving out to have a weight loss effect that is clinically meaningful. The bad news out of all this was, and this is no great news flash, I think, to folks in the audience, is that, as of pre-COVID, obesity levels in the US are continuing to rise. Interestingly, the level of overweight had been somewhat moderating for years, but the proportion of the population that's going into the obese category, people having obesity, a body mass index of over 30, continued to rise. And I think, Robin, two things that struck me right from the outset when we did our exercise was, first of all, again, no great newsflash. Stigma around obesity remains just an enormous factor in dealing with this. Lots of research, for example, to show that even when obesity counseling, prevention, treatment services are available to people that have obesity, very often they don't want to go out and seek it and take it because of the stigma of feeling that they're responsible for their condition. and so on. This despite the fact that clinicians now, 15 years ago, 10 or maybe 10 years ago or so, the AMA anyway, classified obesity as a disease state. And which leads to the other thing that was very striking to us as we did our brief, which is that the science around the causes of obesity really continues to advance and show just how complex biologically it is. People may have seen in the media just in the last week a sort of resurgence of something of a debate in the medical community about how to reframe people's understanding about obesity, that it isn't simply energy in, energy out. If I just exercised and dieted, I could conquer this problem. That's not the experience of people, and it's not supported by the science. The science shows just how hormonally and endocrinologically complex obesity is, and it's a tug of war internally in your system for a lot of reasons. And what that has pointed to, and this is something that we talked about in our paper, is it does point towards an intensification of services around preventing, but also treating obesity, sort of upstream from the consequences, type 2 diabetes, cardiovascular disease, the preventable chronic diseases that we're here to talk about this morning. So maybe I'll stop there, Robin, just by saying that this, for me anyway, personally, as somebody working at NEHI, was one of the big takeaways from the exercise we did pre-COVID. It was that the clinical advice here really is pointing towards intensification of treatment. And of course, that's a huge challenge for the system because of just the sheer number of people we have who have obesity. One last thing, not to skip over COVID. So COVID has just exacerbated this all to the nth degree. People with obesity have been more susceptible to the consequences of COVID. The COVID response itself has meant that the number of people gaining weight have been outnumbering the people that have lost weight during COVID. There's one JAMA study published in the Journal of the Medical Association fairly recently that showed an average of 1.5 pounds per month weight gain across the population. So this is one of the long haul consequences of COVID, is upping the ante around the consequences of obesity. And I'll stop there for now.
Yeah, it's a really great point, Tom, because what your brief also stated was that some of the most hard-fought gains in public health around heart disease, stroke, and other cardiovascular diseases have been reversed as a result. And so, I would like to ask Ernestine, as you think about the impact of COVID on the patients that you're treating, what types of issues are they presenting to you, and have they changed as a result of COVID?
Sure. So I think in general, when people are presenting, it's the kind of adherence issues in terms of taking medications, understanding the information that their providers have given them. That's something that we're working with them. In terms of COVID, access was something, people not able to get the treatments or get the services that they needed in the moment. There was a huge push to do telehealth and all those things, but some people just didn't have access to those types of modalities. So that was one of the things I saw in COVID, like, oh, we have this, but they're not able to access it. And then to be one of the things that we say when dealing with issues like this is, consistency and adherence. And if they're not able to be consistent and adherent, that was getting in the way of some of the huger things, like, in terms of anxiety, depression, dealing with pain, but just access. I think COVID kind of exacerbated that, or for me, I saw that that was a larger thing.
Yeah, that's a really great point. What we're seeing both in the US and globally is mental health has been the #1 well-being issue. So the fact that people are struggling emotionally while they also have medical conditions, while they're also dealing with other societal factors, it has led to this experience of languishing, of burnout, of people that are really struggling. So great point. So let me turn to you, Neil. Based on your extensive background and the work you've done with the Greater Philadelphia Business Group on Health, how can employers help their employees to better manage their chronic conditions such as diabetes, heart disease, and diabetes?
Yeah, it's a great question. And since we are limited in time, I won't give you the full 45-minute answer. But some things, I think a few things we've already hit on in Tom and Ernestine's remarks. But I think there's a lot that employers can do, and that some of their efforts currently are being misdirected towards what they see as low-hanging fruit, but doesn't necessarily solve the problem. So first of all, let me go back to obesity for 1 second. There is not a chronic disease that isn't exacerbated by obesity. There are links between cancer, diabetes, cardiovascular disease, hypertension, almost every disease that you look at. So if you really want to deal with chronic disease, deal with obesity. Also, to pick up on something Ernestine said, adherence. You know, when I ask employers, how adherent are your employees to their medications for chronic disease? No one can answer that question. They're not looking at it themselves. They're not getting it from their consultants. They're not getting it from their health plans. So hold those vendors accountable and ask the important questions. Like for diabetes, what does adherence look like for common drugs? We just did a large study with a multi-employer benefit consultants database and found that people with diabetes were only around 50% adherent to various drugs. And not adherence equals poorer outcomes and higher costs of care. So if you enforce adherence, you may see drug costs go up, but over time, we would think you would see costs overall go down. So don't be so focused on the short term as well. Another issue, I think, Robin, to your point, emotional health is critical, and I would not view it as separate from physical health. For every chronic disease that I've looked at, people with anxiety, depression cost nearly twice as much as people with that chronic disease who don't have anxiety, depression. So make those links. Don't treat things separately with behavioral health and physical health. And within physical health, look at the cost of comorbid emotional or behavioral health issues and try to help them, and make sure that your vendors, if you have a diabetes management program, make sure they are addressing behavioral health, as it's not just your EAP's job, it's everybody's job. Value-based insurance design. Look at your benefit structure and say, am I really doing the right things to promote good management of chronic disease? How many employers are charging co-insurance or co-pays for diabetes drugs and supplies, which creates a barrier? $5 or $10 may not seem a lot to you per month, but to a lot of these employees, particularly low-wage workers, it's the difference between putting food on the table for their family or taking their diabetes medication as prescribed. So think about value-based insurance design and waiving co-insurance, co-pays, deductibles for high-value drugs that will help mitigate the impact of chronic disease. The last thing I'll say, I could go on and on, but I'll say evidence-based programs. Tom mentioned the DPP. If you're not, as an employer, implementing the DPP, I don't know why you aren't. You should. It is evidence-based. Every employer that I've gotten to implement the DPP, 14 of my 50 members, has had a positive experience. But they still see it as a tangential program, like if I can afford to run a cohort. The DPP saves you money. It not only improves outcomes for people, but it saves you money. If you're not familiar with it, look at it, because it's pay for performance. So you're not paying for a bunch of enrollees who never use the program. And to that score, when you're using programs that you're paying vendors for, look at not only who's participating, but who's not participating. We just had a conversation with several employers who were using one of the big diabetes management vendors. And they said, we're getting great outcomes for the 50% of people who are participating in that program. I suspect those 50% of people were already the motivated people who were doing a decent job of self-management. What are we going to do to get those other 50% engaged and to hold that vendor accountable for getting that other 50% engaged.
Mhm.
So look at the big picture, take a population health approach to chronic disease management.
Mhm.
You know, that's a really great point, Neil. I was speaking with a large employer yesterday who was very proud of having engaged 40% of diabetics in a digital solution. But you're right, what about the 60% of people who are opting out? You know, let me toggle back to Tom, because if you could add on to the ideas that Neil has shared, are there other tools and techniques that you might suggest that could offset the costs associated with more intensive prevention and treatment of obesity and type 2 diabetes?
I don't know if I can add a lot other than, again, to sort of reiterate, and I think folks in the HR world are, very aware of this, a proliferating number of these tools ranging from programs like the Diabetes Prevention Program, which, the original version is in person and physical. It may involve going to the YMCA or an on-site someplace on site at the employer, but also can be now delivered digitally. The various telehealth services, online programs that are being described as diabetes remission programs or other lifestyle intervention programs. I would throw in the tools that are available for diabetes management itself, for being prescribed for people that have type 2 diabetes, like this new generation of continuous glucose monitors, which enable so much more tighter but person specific control there, which can be part of this sort of overall program. Graduating up to, there is a hierarchy of interventions here, certainly, and I guess this is the point I think that the clinical guidance is now giving, which is for a certain number of patients at a certain level of risk, lifestyle modification, diet and fitness is just not going to be sufficient. And that's where the question of intensifying up to medications comes in. And so these new agents, non-insulin agents that are proving to have a weight loss effect. And I think worth reiterating that what's clinically meaningful here, and the way to understand this, is that the obesity that needs to be addressed here is not to be addressed from the standpoint of body image or getting thin or any of those things that most of us think about, and most of us that triggers the stigma. It's about weight loss that can be fairly modest if it's sustained, to Neil's point, as an adherence issue, but will be clinically meaningful from the standpoint of reducing the health risk. And so that's a big question here, whether how to get appropriate uptake of these medications. It will be a cost driver, at least in the short term, as Neil is pointing out. But the reduction of risk, we all know what the cost consequences are of developing type 2 diabetes and other comorbid conditions like cardiovascular disease and so on. So anyway, not to go on at great length, but that's I think the way I would look at it. But there's obviously and COVID has brought this to the fore in a major way, certainly, with the explosion in telehealth and other sort of digitally enabled services. There's just a toolbox that's bigger than ever around this.
Yeah, that's great. And I'm really glad that you brought up continuous glucose monitors, because instead of creating a situation where someone needs to take an active role in testing their blood sugar, by having that information available to them and have them getting messages on a regular basis around how their blood sugar may be going up or down and what they can better do to manage it, is going to be really critical to them achieving this whole person health, because life does get in the way. So whether it's making sure that the employers are covering this with very modest or no cost sharing, and making sure that people have access to the supplies they need, it can be quite expensive for individuals to get back to a healthy state of living. Okay, so Ernestine, in the spirit of thinking about whole person well-being, Do you have any suggestions for what employers could do to support the behavioral and emotional health needs of their employees?
Yeah, so I was thinking of just making sure, first asking what they are. That's one of my big things, is how do they know what's going on? And I think when employers ask, and I know there's surveys that people do, but also in terms of, one-on-one conversations that managers have, having that be part of those conversations, and recognizing that it's something that you support versus asking it just to get data. So figuring out how to ask it and making sure that it's just part of the routine is one thing. The other thing is having resources available for people, really knowing what's available. I've had many people come and say, I was handed this sheet. They didn't, know if it was updated, those kinds of things. So making sure that that's an active thing that's, renewed within, if you're offering resources, making sure that they work and that they're appropriate. Offering support for people within the institution, having that available so that people know there is someone that they can go to, or it is supported within the group. And I think people knowing that more and more, I've had people come and say, oh, my manager actually told me about this, and recognize that people cycle through, right? So everybody is not at the same level in terms of, well, here's resources, here's support. People will cycle through and be at different stages and be able to meet them where they're at. I think and I think you get there by asking. So it's taking me all the way back to the beginning, but I think those are things. It's a lot of people have talked about, they've gotten encouraged to reach out and maybe come see someone, but they're not able to leave for their appointments, or so recognizing that those go, that if you're encouraging people to secure these services and to really take care of themselves, that takes time, and then seeing that as an investment in themselves rather than that they'll be punished for doing what we say they need to do to take care of themselves.
Yeah, that really aligns very well with the research on what employees want from their organization in order to reduce the feeling of stress or burnout. It's not just that they want to be able to take the time off to meet their needs, but they need a supportive manager that allows them the flexibility. They need an organizational culture that enables them to shut down and help to achieve work-life balance. So I love the way you kept bringing in the word support, because that's really what it's all about. It's about understanding what employees want, not just what they need, and really helping to get to that emotional response that drives behavior change. So employee listening, I think, is right at the beginning of that conversation. So that's awesome. So let me go back to you, Neil. I understand the employer action brief that the Greater Philadelphia Business Group on Health put out in March 2019 encouraged your employer members to cover anti-obesity medications. Can you tell us why you've taken that position and what advice you have for employers?
Sure. So we're actually in the process of updating that brief because there have been some newer anti-obesity medications have become available since we wrote that. But I still stand firmly in support of employers covering AOMs. The reason is obesity is prevalent. It has a significant impact on health outcomes. It should not be, to Tom's earlier point about the stigma of obesity, why are we treating obesity differently than every other chronic disease? I have never heard an employer say, let's talk about whether we should cover hypertension drugs, or whether we should cover lipidemia drugs, or even rosacea drugs, or any other dermatologic condition. So why do we say, if obesity has such a significant impact and it's a real physical health disease, why are we having this conversation at all? I don't get it. So philosophically, clinically, I think it makes a lot of sense. I think what's happening is employers are concerned about the cost of these drugs, seeing the prevalence of obesity, and concerned about, if I cover this drug, it is going to open the floodgates. So I'll say first, from employers who have done it, we have seen no evidence that suddenly everybody is clamoring for anti-obesity meds. But also, as an employer, you can still cover a drug and put limitations on its use, prior authorization. Make sure the people getting it meet the clinical definitions. One of the recommendations is you should not be on an anti-obesity medication if you're not also in a lifestyle change program.
Mhm.
So you can require that, just like employers in the past have required participation in a diabetes disease management program to get your free drugs and testing supplies. Also, most of the AOMs, as far as I know, and I'm not a clinician, but if the AOM hasn't worked within 12 weeks, stop it. So the prior auth can be limited to up to 12 weeks, and then you have to reauthorize if the person has achieved the 5% weight loss. So that's another safeguard on it. Finally, I'd say if you as an employer are still really concerned about who's writing these scripts and do they know what they're doing, you can require that the patient see a weight management specialist. There's a growing number of physicians who are board certified in weight management, and you can identify, I don't know what the Rhode Island provider market looks like, but with telemedicine, you could even have a telemedicine referral. Consult is the word I was struggling for this morning. Again, I think the main point is take a critical look at if you're not covering AOMs, why not? And I would advise that you reconsider that position.
Hey, Neil, let me stay with you for a quick sec. So
Sure.
we've talked about, and you shared some really great examples of how employers can protect themselves financially from this influx of major expense. But what about those folks who aren't engaging and aren't using the programs? Are there communications, engagement strategies, or incentive designs that you're finding are working to engage those people who generally are disengaged?
That is the $64,000 question that we get all the time from the employers. I wish I had an easy answer for Robin and all the other people in the room today. I think it is a challenge. My only advice, and something we're starting to look at, is really start to take a population health approach to segment the population. And rather than say we're getting 50% engagement, say, here's how much engagement we're getting for this group identified by race, ethnicity, by age, by gender. Let's slice and dice the population, and let's not be afraid to ask people who are not engaged why they're not engaged. Is it that they're not aware of the program, that there's some financial barrier we're not aware of, there's some distrust of the program or the employer? There are probably 15 different reasons that we'll see come up if we start to ask people, why are you not engaging? And we can't get to solutions without having those conversations.
Mhm.
That's a great point. And it goes back to Ernestine's suggestion that you really need to do listening. You need to ask your employees what they want. So it's not just what can we offer, but why are you not using what's available to you? Because awareness can be a barrier, but it's also, do you not feel like you're part of a social community? Are we not meeting you where you are? Are we not addressing the most basic issue? If you're struggling financially, it's really hard to address your physical health, right? So if we can get to those most basic issues, great ideas. Tom, let me ask you, what can we do in Rhode Island as employers and members of the healthcare community to help change the trajectory for our employees, members, and patients struggling with these chronic conditions?
Well, I guess two things come to mind, and this is a difficult issue for all the reasons Neil just described. I think that one thing in a way would be to try to bring home to employers and from them to their employees that there is a trajectory that can be bent here. Robin, you mentioned the references we made in the brief we did a couple of years ago about cardiovascular risks going up and progress that had been seen over 50, if not 60 years in reducing cardiovascular disease in America was starting to turn around because of obesity. And we cited some research that was fresh at that point that showed that in Medicare, for example, the cost curve really was bent over 50, 60 years. There was a lot of illness that did not happen. This is through modeling, to be sure, but a lot of illness that did not happen in the life of the Medicare program because smoking cessation, for example, to something that Ernestine's focused on, reduction in smoking, reduction, better diet, and so on and so forth. And so Medicare would be more costly today, but for that progress, is now at risk because of obesity. So I guess faith that there is a curve that can be bent is one thing. The second thing I think would be to try to bring home, starting with maybe with employers, and then on to employees, that the science really does back up this framing here, that this is not a matter of, yes, you have to have a will to engage in the diet and fitness programs. To Neil's point, lifestyle remains a bedrock fundamental, starting point of all the clinical guidance and the clinical practice guidelines around obesity prevention, treatment, and diabetes prevention in treatment. For all that. But this is being scientifically shown to be this very sort of complex condition for a multitude of reasons. Some people are more inclined to lose weight versus gain weight. Keeping weight off is an enormous endocrinological challenge. There's research to show that just from a standpoint of evolutionary biology, we're programmed to put it back on. For most of human existence, we've been facing starvation. And so we're sort of wired to, not keep weight off in a lot of ways. So understanding that, because it's crucial to overcoming stigma, is just foundational to all of this. And finally, I think I want to say, it's easy for me to say as somebody in a think tank, more experience with the sort of population health management kind of thinking that Neil talked about strikes me as probably, essential to give employers, purchasers, insurers, and individuals more confidence that there are strategies that can work. And a population health management approach, including segmenting, slicing, and dicing, might orient this a little bit more towards individuals understanding this is a matter of their health risk. We need to talk to you about your engagement, what would motivate you to engage in this, because understand, you are in a, susceptible to a certain kind of risk, heart disease, kidney disease, whatever the case may be. So it's a complicated answer. Nothing is simple in this field, but that would be my, sort of top of mind thoughts.
Yeah, to kind of summarize what I'm hearing, it's about positivity and empowerment. To believe that we can make a dent, that we can make a difference, and to feel empowered that we actually can accomplish that. I think about New Year's resolutions. The number one New Year's resolution in the United States is around, I want to lose weight, I want to eat healthier, I want to exercise more. People actually want to do these things. And so how can we meet them where they are, make healthy choices easy for them, but also create an environment where it's okay for them to take care of themselves and not to think that self-care is selfish, because it's not, right? So in the spirit of self-care, as we end our panel discussion, I would love to ask Ernestine, if you have any advice for attendees that are on this session right now. Are there self-care techniques or other approaches that can help people support their own emotional needs during these continuing stressful times?
Yeah, so we started with one when we opened the meeting with a mindfulness practice. I know that people have different experiences with mindfulness. I talked to a lot of people that got like the Headspace app and Calm at the beginning of the, and then those are great. But I think it's even easier than that. I tell people, you've been breathing your whole life, like practice that. And so really kind of taking in oxygen and kind of what that does for the body. I do a whole thing on stress, and just breathing in good oxygen is great for us and helps us make better decisions. So if you're not into meditation and things like that, but finding a time where you can just be still and allow your body to kind of resume that. But then I have people who are movers and shakers. So of course I'm going to promote physical activity. If you have to move, it's a form of meditation too, I say. I think about people who run and how rhythmic they are. I'm like, that's beautiful how you keep form, and that's the meditation practice. So being able to move, we know that's helpful in terms of stress relief, and also just in terms of dealing with mood, anxiety, depression. One of the other things I'll talk a little bit more about that I rarely hear is sleep. We need sleep, people. And so making sure that you're paying attention to, okay, how much sleep am I getting? How do I get it in? There's sleep hygiene things, turning off your electronics, those kinds of things, but also setting up your environment in your home. I tell people everything out of your bedroom except your bed for sleep, because it promotes that's the time when we rest. We think about obesity and the impact of lack of sleep on obesity, and the regulation of different hormones that happens when you sleep. And so recognizing the impact of the basics in terms of activity and sleep and just being still, but also kind of how it all fits together, right? So psychologically, emotionally, even spiritually, I talk to a lot of people, making sure you're staying connected with your faith, or if you don't have one, your beliefs, but the community, like all of that, you think of the onion in terms of dealing with public health, all of that fits together. And so paying attention to that on your individual level, and then how that you can't be any good to anybody else, right? If you're not taking care of yourself. So making sure that stays at the forefront.
That's awesome. I just read recently that when you ask people how they measure their mental health, 45% of people say they measure it based on their mood. 28% say they base it on their sleep. And so if we could maybe try to reduce some of the stigma associated with mental health, or stigma associated with obesity, and just ask people, what kind of mood are you in today? Or, hey, did you have a good night's sleep last night? It starts to kind of normalize the conversation, because that's how human beings are actually thinking about their health. So that's awesome. So for any attendees, if you have any questions, I encourage you to enter them into the Q&A or the chat. And at this time, I would like to introduce Melissa Porcelli from Novo Nordisk. Melissa has helped me to co-chair this event, and she has been instrumental really in helping pull this together. So Melissa, I first want to thank you so much for your contributions to this. And I want to just give you the opportunity to share with everyone the new toolkit that we have posted on the RIBGH website. Thank you, Melissa.
Sure. Thank you so much, Robin. And really a big thank you to all our panelists for sharing your thoughts and research on this important topic. For all of those on the line, there have been several resources mentioned today by our panelists, as well as some tools from the Rhode Island Department of Health, and some other very helpful websites and links that can help you and your organizations better understand and combat the chronic diseases that our panelists spoke about today, specifically diabetes, cardiovascular disease, and of course, obesity. So Rhode Island Business Group on Health will send a follow-up email with links to this toolkit. However, you can find it rather easily just by navigating to the Rhode Island Business Group on Health website, clicking on the Health and Productivity tab, and then clicking Employer Toolkit. If you have any questions at all about the resources in the toolkit, please reach out to us and we'd be happy to help you navigate them. With that, I am going to turn this over and introduce Deborah Newell. Deb is the director of the Diabetes Education Partners of Rhode Island and coordinates the Rhode Island Certified Diabetes Outpatient Educators. She serves as the co-chair for Rhode Island World Diabetes Day Planning Committee and is here today to share some news about this year's events with you and how you can engage your employees and community. So I'll turn it over to you, Deb.
Thank you, Melissa, and good morning, everyone. I appreciate this opportunity to let everyone know about World Diabetes Day and how we will be promoting diabetes awareness in Rhode Island. Tom, Neil, and Ernestine all made some great points this morning, and I appreciate all their input. As you may already know, Rhode Island World Diabetes Day has had a presence in our state for several years, and this is the second year we will be fully virtual. We are also launching a corresponding 4-week challenge called the 2021 Road to Wellness Challenge. The committee has worked diligently to put together a half of a day of thoughtful and dynamic programming to be presented on Saturday, November 13th. The motivational and inspiring online presentations include a discussion by J.C. Argonne, a professional tennis player, an ADA presentation on Know Your Diabetes by Heart, a trivia contest by Al Lewis from Quizify, a cooking demonstration, and more. In conjunction with our event, like I said before, we are hosting the 2021 Road to Wellness Challenge. This is a 4-week health and wellness challenge focused on building healthy habits. It's designed to help participants make lifestyle changes to improve wellness and quality of life. There will be a special kickoff for the challenge on October 6th, featuring special guest, Dr. Judson Brewer. Dr. Brewer is an expert in mindfulness and building healthy habits and breaking bad habits also. Members of the challenge will set SMART goals and track their progress daily on our challenge calendar. Weekly emails with encouragement and new topics will be emailed, and there will be weekly activities including yoga, Zumba, cooking demos, guided meditation, and much, much more. And then to make the journey even more fun and rewarding, there will be prizes. Prizes for participation and prizes for who does the best and prizes for completing the surveys. So you can win a chance to win a prize. Now, more than 1 in 10 Rhode Islanders are living with diabetes, and more than 1 in 3 Rhode Islanders are living with pre-diabetes or are at risk of developing diabetes. And the scary thing is that many don't even know it. Right now, Rhode Island World Diabetes Day has never been more important with COVID-19 in our midst and the increase of risk of severe illness with COVID-19 among individuals with certain underlying health conditions like diabetes. Since you are all champions of health in Rhode Island, I'm hoping you will consider sponsoring this year's event. In keeping with the theme for the World Diabetes Day, access to diabetes care, money raised will be donated to a charitable organization to support diabetes care for patients who are uninsured or underinsured. Information and sponsorship forms can be found on our website at www.ridwdd.org. So please help us spread the word about Rhode Island World Diabetes Day with your networks and your employees. We appreciate any support you may provide and welcome your participation in the 2021 Road to Wellness Challenge and the Rhode Island World Diabetes Day 2021 event. Be sure to sign up on our website. I think we put it in the chat, www.ridwdd.org. Mark your calendars with the important dates. October 6th is the kickoff for the challenge. The challenge runs from October 11th to November 7th. And then our Rhode Island World Diabetes Day event will be held on November 13th virtually. Please don't hesitate to reach out with any questions you might have, and hopefully we can all work together and support this initiative and take steps toward a healthier Rhode Island and a healthier you. Thank you, everyone.
Thank you, Deb. And I'd like to just take a moment. If anyone has any questions, again, you can enter those into the chat or into the Q&A. There's also in the chat, if you open it up, there is a link to the CDC Workplace Health Resource Center. You can access that for information for your employer-sponsored programs in order to support the prevention, risk reduction, and treatment of diabetes, heart disease, obesity, and other conditions. So we encourage you to take advantage of those resources. Make sure that you check out the new toolkit on the RIBGH website. Hopefully today you feel positive and empowered to make better decisions that will generate better outcomes for yourself, for your family, for your community, your organization, for our society. I'd like to thank Tom Hubbard, Neil Goldfarb, Ernestine Jennings as our panelists today. I'd like to again thank Melissa Porcelli for her support pulling this event together. Thank you, Deb, for representing the Rhode Island Department of Health. And I would now like to hand off to Al Charbonneau for final remarks.
Look at that, in 2 clicks, I'm back on. I too would like to thank the speakers, Tom, Ernestine, Neil, and Melissa for their contribution. Deborah, I'm sorry for dropping you out. And most importantly, I'd like to take a moment to thank Robin Bouvier. This woman, Robin, has done a tremendous amount of work for the Rhode Island Business Group on Health. Every time she has led something, it's innovative, it has legs, we record it, it ends up on our website and helps employers throughout the years. So I just really personally want to thank Robin. I know the board is extremely pleased with her contribution to the Rhode Island Business Group on Health, and we wouldn't want to close out today's event without saying that. Finally, I'll say we're going to give you a few minutes back, 5 minutes back, but I want to make the point that our next event is November 19th. We have scheduled that in person, quote, in person, COVID dependent at the Marriott. You'll see more on our website. Thank you for joining us today. Once again, thank you for the panelists. Thank you for Melissa. And thank you for Dana for organizing this event. Thank you.